We take about 20,000 breaths a day, and most of the time we don't even think about it. It's this like perfect invisible transaction where oxygen just goes exactly where it needs to, and you just go about your day.
Right. Yeah, it feels completely airy. It feels weightless.
Exactly, weightless. But when you look at the medical notes on pneumonia, you realize how quickly that airy lightness can just vanish.
Oh, it changes entirely. The physical environment of the organ just completely transforms when this specific type of inflammation takes hold in the deepest parts of our chest.
Which is exactly what we are unpacking in today's deep dive. So we are going into the source material to answer a pretty terrifying mechanical question, really. Like, how does an invisible pathogen turn your healthy lung from this lightweight air-filled sponge into a waterlogged brick?
A waterlogged brick is a very good way to put it, actually.
Right. I mean, we all know the word pneumonia. We hear it constantly, but we rarely talk about what is actually happening down in the dark when we get it.
Yeah, and to really understand that microscopic battlefield, we have to kind of rethink our standard definition of what a disease even is.
What do you mean?
Well, when you think of an illness like, say, influenza, you're thinking of a condition defined by a specific bug, right, like the influenza virus.
Yeah.
But pneumonia isn't defined by the bug at all.
Okay.
It is defined entirely by the territory.
Ah, so it's all about location, location, location.
Exactly. It is an infection of the lung parenchyma.
Parenchyma, right.
Yeah, which basically means that terminal bronchioles, the alveolar ducts, and the alveoli themselves.
The actual air sacs.
Right. Those microscopic balloon-like sacs at the very end of your respiratory tract where the gas exchange actually happens.
Where the oxygen crosses into your blood and carbon dioxide crosses out.
Exactly. So pneumonia is simply the mechanical endpoint of what happens when an infection or an irritant reaches those distal air spaces.
So it's basically a description of a territorial invasion, which I guess explains why the sources show that bacteria, viruses, fungi, or even like inhaled chemicals can all cause it.
They absolutely can.
But looking at these notes, the medical community seems to argue constantly about where the line is actually drawn, depending on their specialty.
Oh, yeah, the definition gets very blurry at the edges. I mean, a pathologist looks at it through a microscope. So they define pneumonia by physical evidence in the tissue.
Like what kind of evidence?
Specifically, white blood cells called neutrophils and a sticky protein called fibrin just packed into those alveolar sacs.
Okay, so that's the pathologist.
Right. But a radiologist defines it by what they see on a scan. They're looking for a white cloud or a shadow on a chest x-ray, what they call an infiltrate or a consolidation.
And then there's the bedside doctor, right?
Exactly. The clinician standing right there at the bedside defines it functionally based on the patient's symptoms. Fever, a productive cough, decreased oxygen.
Wait, let's play this out because those three definitions have to conflict in the real world at some point, right?
They definitely do.
Like if a bedside doctor needs to see that shadow on an x-ray to confirm the diagnosis, but the patient comes in severely dehydrated.
Oh, this is a classic scenario.
Yeah. Couldn't the x-ray look totally clear just because they don't have enough fluid in their body to actually cast a shadow?
They could have a completely clear scan.
Yeah.
Yeah, if a patient is incredibly dry early in the illness, they might have the fever and the cough.
Right.
And they might even have the microscopic tissue damage of pneumonia. But because fluid is required to make it infiltrate visible on an x-ray, the imaging just misses it.
Wow. So the disease is destroying the tissue, but the camera can't see it because the raw materials for the shadow are just missing.
Exactly. And, we see the reverse scenario too.
Oh, really?
Yeah, a patient might inhale a severe chemical irritant, like, say, aspirating stomach acid.
Ouch.
Right. That acid burns the tissue and triggers massive inflammation, which then pulls fluid into the lungs.
Okay, so there's fluid now.
Right. And on an x-ray, that chemical fluid looks absolutely identical to a bacterial pneumonia infiltrate, even if there isn't a single bacterium present in their lungs.
That is wild. Okay, so the defining feature isn't the bug, it's the flooding of these deep, tiny air sacs.
Yeah.
So let's zoom in on the exact mechanical steps of how that location gets flooded, because it's clearly not just, water pooling in a bucket.
Not at all. We have to start with the baseline architecture first. An alveolus is built to stay dry and open.
Okay.
It's this fragile sac, just one single cell layer thick, completely wrapped in tiny blood vessels called capillaries.
And there's a coating too, right? The notes mentioned a coating.
Yeah, you have a slippery lipid protein mixture called surfactant. It coats the inside to keep the delicate walls from just collapsing in on themselves.
Like a wet paper bag or something?
Exactly. And you also have resident immune cells, alveolar macrophages, just constantly patrolling the area for debris.
They're like the local security guards.
Basically, yeah.
But clearly, pathogens find a way past them. Like the notes highlight Streptococcus pneumonia as a classic culprit here.
Oh, pneumococcus is a master at this.
Because it comes armed with this slippery polysaccharide capsule, which basically acts like Teflon armor, so those macrophage security guards just can't swallow and digest it.
Right, they try to grab it, but it just slips away. So once the pathogen evades that initial defense and begins multiplying in the air sac, the macrophages realize they are completely outgunned.
So what do?
They release chemical distress signals called cytokines. You'll see acronyms in the immunology notes like IL-1, IL-6, and TNF, or tumor necrosis factor.
Wait, those are the exact same cytokines we heard so much about during the pandemic, right? The whole cytokine storm discussion.
The very same ones, yes.
So they act like molecular flare guns to call in backup.
They call in massive numbers of heavy-duty immune cells from the bloodstream. But to get those backup cells from the blood into the lung tissue, the cytokines have to do something really dangerous. They make the capillary walls incredibly leaky. The blood vessels surrounding the air sac become highly permeable.
Oh, wow. Which means the blood plasma just pours through the walls.
Yes. Protein-rich plasma floods out of the vessels and straight into the alveolar airspace.
Just completely flooding the zone.
And riding that wave of fluid are millions of neutrophils, the heavy infantry of your immune system.
Right.
They flood the phages, they attack the bacteria, and then, well, they die in place.
They just die there.
Yeah, and when they die, they burst open, releasing their own digestive enzymes in their DNA.
Adding all this cellular wreckage to the floodwaters, I mean, it sounds like our immune system is calling in a massive SWAT team for a minor trespasser, and the SWAT team ends up detonating explosives and demolishing the entire house.
That is a perfect analogy.
Yeah.
The house is left packed with this toxic, sticky, protein-heavy mixture we call an exudate.
An exudate.
Yeah. This biological-friendly fire is often far more destructive to the lung tissue than the original pathogen's activity ever was.
Okay, so if the air sacs are packed with this inflammatory sludge and the patient can't breathe, my instinct would be to just, I don't know, put an oxygen mask on them and force more air in.
A lot of people think that.
But looking at the mechanics of this, that wouldn't actually solve the core problem, would it?
No, it only partially helps. And that's because of a mechanical failure called an intrapulmonary shunt.
A shunt.
Yeah, think about the blood flow for a second. Blood is still pumping past that flooded alveolus through the capillaries, just like it always does, expecting to pick up oxygen.
Because the heart doesn't know the lung is flooded.
Right. But the sac is full of fluid and dead cells instead of air, so no oxygen can physically cross that sludge to reach the blood.
Oh, man. So the blood just keeps moving completely empty-handed and returns to the heart just as deoxygenated as when it arrived.
Exactly. We call this a VQ mismatch.
BQ.
Yeah, V stands for ventilation, which is the air coming in, and Q stands for perfusion, which is the blood flow.
Okay.
So in this flooded sac, the blood flow, the Q, is totally normal, but the ventilation, the V, is zero.
Right.
If you put a high-flow oxygen mask on that patient, you're only pushing extra oxygen into the healthy, dry alveoli that are still open.
Because the flooded ones are blocked.
Yes. You're doing absolutely nothing for the deoxygenated blood that is being shunted right past the flooded, blocked ones.
That is a terrifying physiological bottleneck. Wow. But what's fascinating is that knowing this microscopic mechanism actually allows us to look back at history and understand exactly what doctors were observing centuries before microscopes even existed.
The clinical picture has been remarkably consistent throughout history. I mean, Hippocrates described the fever, the sharp chest pain, and the rust-colored sputum back in the 5th century BCE.
Wait, the sputum is rust-colored because of the red blood cells leaking into that inflammatory exudate we just talked about?
Exactly. The blood mixes with the mucus. But the physician who really mapped the physical reality of this disease was René Laennec in 1819.
The stethoscope guy.
Yes. He invented the stethoscope, which, back then was initially just a hollow wooden cylinder.
Just a tube of wood.
Pretty much.
Yeah.
And he spent his time correlating the specific acoustic sounds he heard through that wooden tube with what he found when he performed autopsies on those same patients after they died.
Because sound travels differently through different mediums. Like a lung filled with fluid and cellular debris is going to transmit sound much better than a healthy air-filled lung, just based on physics.
Precisely. He was diagnosing a cellular-level immune war simply by listening to the acoustics at the bedside.
That is brilliant.
It really was. And when Lennox looked at those lungs during autopsies, he coined a term that pathologists actually still use today.
Hepatization.
Yes, hepatization.
Hepatic meaning liver.
Right. The lung becomes so packed with this heavy exudate, the fluid, the fiber, and the dead neutrophils, that it literally changes texture.
It becomes solid.
It becomes dense, solid, and looks and feels exactly like a piece of liver. Pathologists used to demonstrate this simply by dropping a piece of the diseased lung into a bucket of water.
Oh, wow. Because a healthy lung is a sponge, so it floats.
Exactly. It bobs right at the top.
But this hepatized lung would sink straight to the bottom because the air that normally provides buoyancy has been entirely displaced by the battleground debris.
It just sinks like a stone.
Which begs the question, if your lung turns into a solid, heavy organ that sinks in water, how on earth does it ever get back to normal? Like, you don't just cough up a liver?
No, thankfully you don't. The body has to dismantle it from the inside. Well, Lehenick mapped out the stages of this classic lobar pneumonia. It starts with congestion, moves to red hepatization where it's packed with red blood cells, and then gray hepatization as those cells break down into a dense fibrinous mass.
Okay, so it gets worse before it gets better.
Right, but the final stage is resolution.
The cleanup crew.
Exactly. It's honestly an enzymatic miracle. Special enzymes arrive and literally digest the solid fibrinous sludge.
They just melt it away.
Basically. They break it down and liquefy it so it can be reabsorbed by the lymphatic system or cleared out by those macrophage sweepers we talked about.
So the lung painstakingly rebuilds its empty air spaces cell by cell.
Yes. It is incredible the body can reverse that level of destruction.
It really is. But, before we had antibiotics to help our bodies survive long enough to actually reach that resolution stage, this was a massive killer.
Oh, absolutely devastating.
Like, Sir William Osler, the legendary physician, he wrote a textbook in 1901 calling pneumonia the captain of the men of death.
Yeah, in the pre-antibiotic era, a fast-moving lobar pneumonia would kill up to a third of the people who caught it, often within a single week.
That is staggering.
And we can see how this underlying mechanism of alveolar flooding scales up in different real-world scenarios, even today.
Like what?
Well, we just talked about classic lobar pneumonia, which fills a whole anatomical lobe. But consider the famous historical mystery of Legionnaire's disease in 1976.
Oh, right. That was the outbreak at the American Legion Convention at a hotel in Philadelphia. Over 180 people got severely sick, and I think 29 died.
Yeah. And investigators eventually found a previously unidentified bacterium. They named it Legionella pneumophila. But the real breakthrough was discovering how it infected them.
Right, because it wasn't spreading person to person through coughing, was it?
No, not at all. The bacteria had actually colonized the hotel's air conditioning cooling tower.
So it was being aerosolized and pumped right through the ventilation system.
Exactly.
Which proves you don't need a sick neighbor to get pneumonia. Breathing in contaminated environmental water droplets can carry bacteria deep into those terminal air sacs and trigger the exact same catastrophic cytokine alarm and flooding cascade.
It's the exact same endpoint. And, we saw another devastating variation of this mechanism with COVID-19. The SARS-CoV-2 virus operates a bit differently at first, but it reaches the same mechanical endpoint. The virus specifically targets the type 2 pneumocytes.
Wait, remind me what those are.
Those are the exact cells lining the alveoli that produce the surfactant.
The slippery coating that keeps the air sacs open.
Yes.
So the virus latches onto the ACE2 receptors on those specific cells.
Right. And by destroying the surfactant-producing cells, the virus triggers what we call diffuse alveolar damage.
Diffuse meaning everywhere.
Exactly. Instead of filling just one lobe of the lung like a classic bacterial infection, it causes widespread damage across both lungs simultaneously.
Which completely explains why we kept hearing the term ground glass opacities on the news during the height of the pandemic.
Yes. Because on a CT scan, you don't see a solid white block of lobar consolidation. You see this hazy, shattered glass look scattered everywhere.
And that's the fluid and inflammation.
Right. And in its most severe form, this progresses to ARDS, or acute respiratory distress syndrome. The flooding is so widespread that the intrapulmonary shunt becomes massive.
There is virtually no dry land left for oxygen to cross over.
None. Which is why patients would fail to oxygenate even when put on a ventilator.
Wow. Because pneumonia is this generic mechanical endpoint that can be triggered by a virus, a bacterium, or a cooling tower, it really is surrounded by a lot of historical myths and blurry definitions.
Oh, tons of them.
Like, take the 1918 flu pandemic.
Yeah.
The autopsy studies from that era showed that a massive number of deaths weren't caused purely by the influenza virus itself.
No, they were caused by a two-hit model. Pathogens often cooperate in lethal ways.
How so?
Well, the influenza virus came in first, damaged the airway lining, and basically stripped away the mucociliary defenses. It essentially blew the doors off the hinges.
Leaving the lungs completely vulnerable.
Right. And with the defenses down, a secondary wave of bacterial pneumonia, often pneumococcus or staphylococcus, marched right in and flooded the alveoli.
And we still see this two-hit phenomenon today, right? Like with modern flu or COVID-19 patients who suddenly develop secondary bacterial pneumonias halfway through their recovery.
We absolutely do. It's a major complication.
Which brings up the blurry line between pneumonia and pneumonitis. The sources use both terms, and frankly, they sound nearly identical.
They are very similar. They involve inflammation of the exact same deep alveolar tissue, but the distinction actually dictates the treatment.
Okay, break that down for us.
Pneumonia implies an infectious pathogen, like a live bug actively multiplying. Pneumonitis is typically reserved for non-infectious causes.
Like radiation damage or something.
Yeah, radiation, an autoimmune flare-up, or aspirating that stomach acid we mentioned earlier.
But wait, if aspirating acid looks exactly like a bacterial infection on an X-ray, that has to be a total nightmare for the clinician.
Oh, it is.
Like, if a patient breathes in stomach contents, you can't easily tell if the inflammation on the scan is just chemical pneumonitis from the acid or an infectious pneumonia from mouth bacteria that traveled down alongside the acid.
You really can't. That uncertainty is exactly why prescribing antibiotics for aspiration is such a heavily debated topic in hospitals today.
That makes so much sense. Let's talk about antibiotics and some of the broader misconceptions floating around. A lot of people think pneumonia is just, a really bad chest cold.
That is a very common myth.
But based on the anatomy we've discussed, a cold is confined to the upper respiratory tract. Your nose, throat, major airways. Pneumonia is a completely different anatomical compartment down in the gas exchange units.
Exactly. Another common one is the idea that walking pneumonia isn't real pneumonia, that it's just like a mild lingering cough.
Right, people say that all the time.
Yeah, but walking pneumonia is just clinical slang for atypical pneumonia, often caused by a bacterium called Mycoplasma pneumonia.
So it is real.
It absolutely causes real alveolar inflammation and exudate. It's just a slower-moving pathogen than classic lobar pneumonia, which allows the patient's body to compensate enough to remain upright and ambulatory, hence walking pneumonia.
Ah, I see. Then there's the really dangerous assumption that if you have pneumonia, you just need a Z-Pak or some antibiotics and you'll be fine.
Right, and that is a huge problem. Because many pneumonias, especially in young children and during peak flu season, are entirely viral.
And antibiotics do absolutely nothing to viruses.
Nothing at all. Furthermore, decades of demanding antibiotics for every cough has driven the evolution of multi-drug-resistant Streptococcus pneumonia.
We basically created a superbug.
We did. We took a bacterial problem that was largely solved in the 1940s and evolved it right back into a lethal threat.
Wow. I want to clarify a few neighboring medical terms that people might confuse with pneumonia. If pneumonia is inflammatory fluid leaking into the air sac, what happens when someone has congestive heart failure and their lungs fill with fluid? Is that the same thing?
No, you're talking about pulmonary edema. Edema also fills the alveoli with fluid, but the mechanism is totally different.
How so?
It's a pressure problem, not an inflammatory leak. The failing heart causes fluid to physically back up and push into the lungs.
So it's not immune cells.
Right, the fluid is just a low-protein transudate, basically water. Pneumonia, as we've established, is a high-protein, sticky exudate driven by the immune system physically tearing open the blood vessels.
Got it. Okay, what about when the air sac just collapses?
That is atelectasis. The alveoli collapse, usually because a larger airway upstream is blocked, or the patient is in pain and breathing too shallowly to pop them open.
So the sac isn't filled with fluid at all?
No, it's just squished empty, like a deflated balloon.
And what about pleural effusion? That sounds like fluid, but the name implies it's somewhere else.
Pleural effusion is fluid accumulating completely outside the lung tissue, in the potential space between the outside of the lung and the inside of the chest wall.
Ah, okay.
Pneumonia can cause it through proximity inflammation, but the fluid is pooling in a completely different anatomical zip code.
Okay, here's a phenomenon from the notes that honestly just blew my mind.
Right.
Say you get bacterial pneumonia, you get the right antibiotics, you survive the fever, you feel totally fine, and you are ready to go back to work. But your doctor takes a follow-up chest x-ray 2 weeks later and says your lungs still look terrible. Why does the picture lag so far behind the patient?
Because radiographic resolution takes significantly longer than clinical resolution.
Right, but why?
Well, you feel better because the live bacteria are dead, the cytokine alarm is shut off, and your body is no longer in a state of systemic panic. But your alveoli are still physically packed with that solid, fibrinous sludge.
The biological garbage trucks are still working.
Exactly. It takes weeks for your localized enzymes to digest and exudate, and for your lymphatic system to cart all that debris away.
It's a massive physical demolition and cleanup job.
It is. And the X-ray is going to show that shadow until the debris is completely cleared out.
That is fascinating. Well, we've spent this whole time down at the microscopic level looking at cells and fluid. Let's kind of pull back and connect this pathophysiology to the broader world. Pneumonia is not just a disease of the past, it remains one of the leading infectious causes of death globally. And the data shows it disproportionately targets two specific groups: young children and adults over the age of 65.
It targets them because those two populations have the lowest physiological reserve capacity.
Meaning they can't afford to lose any lung function.
Right. When you are very young or very old, you simply cannot tolerate a large percentage of your alveoli going offline. You don't have the biological buffer to survive a massive intrapulmonary shunt dropping your blood oxygen levels.
Which really reframes how we should think about vaccines. The pneumococcal conjugate vaccine, or even just the annual flu shot, aren't just there to prevent a cough or keep you from taking a sick day.
No, they are vital public health tools. They are specifically engineered to stop this exact alveolar flooding cascade before the first cytokine alarm is ever tripped.
And if there was one thing the COVID-19 pandemic did, it made this hidden pathophysiology totally household knowledge. I mean, millions of people went out and bought pulse oximeters, those little finger clips, for their medicine cabinets.
Yeah, and the only reason we all bought them is because they directly measure the downstream consequence of alveolar flooding.
Right. When the virus caused that diffuse alveolar damage and the intrapulmonary shunt began blocking oxygen, the pulse oximeter acted as our early warning system that the alveoli were filling up.
It told us the shunt was happening before the patient even felt breathless sometimes.
This disease also carries a quieter, almost philosophical cultural history, too. We mentioned William Osler earlier, calling it the captain of the men of death. But looking through the historical notes, he also had another very different name for it.
He did. He called it the old man's friend.
Which sounds so contradictory.
It does, but you have to remember the era. Before the advent of antibiotics, many elderly patients suffering from prolonged, painful terminal illnesses, failing slowly from cancer or heart disease, would eventually contract lobar pneumonia.
Because their immune systems were weakened.
Right. And because the pneumonia moved so incredibly fast, often ending in a sudden crisis within just days, it offered a swift, comparatively peaceful end to what would otherwise be months of drawn-out suffering.
It's a really sobering reality of how intertwined our immune responses are with our overall vitality.
It really is.
It's wild to think a disease can be both a terrifying captain of death and a merciful friend, entirely depending on the context of the patient's life.
It all depends on the reserve capacity we talked about.
Exactly. Which brings me to a final thought for you to chew on as we wrap up today's deep dive into the sources. We learned today that the deadly flooding of the lungs isn't just the bacteria multiplying. It is largely caused by biological-friendly fire.
The cytokine storm and the neutrophils.
Right. It's our own immune system overreacting, tearing down the capillary walls, and demolishing the house to catch a trespasser. So, if the damage is self-inflicted, could the future of surviving severe respiratory diseases rely less on finding new, stronger antibiotics to kill the invaders, and more on learning how to negotiate a ceasefire with our own bodies?
That is exactly the ultimate frontier of immunology right now. If we can learn how to selectively silence the cytokine alarm before the neutrophils destroy the tissue, we might completely change the course of respiratory medicine.
Because at the end of the day, we just want to keep that delicate, lightweight sponge full of air and stop it from ever turning into a waterlogged brick. Thank you so much for joining us on this microscopic journey into the lungs. Keep breathing easy, keep asking questions, and we'll catch you on the next deep dive.